Don't be shy. I have been known to drop this in a person's lap, but that's okay. This lab coat doesn't button down far enough. I'm going to get stuff on me here. Here we go. As I said, this doesn't look much like a heart, but what you're looking at is fat that's adhering to the what we call the parietal pericardium. The pericardium, you may remember my saying, has two layers. It has an inner, which is the visceral pericardium, which we will have another name for later too. And then the outer part, which is tougher, is the parietal pericardium. Well, this fat is adhering to the parietal pericardium, and you'll see it as I rip it away. It's kind of unpleasant, but I'm going to have to rip this fat away and put it on this paper over here. Chemically, what kind of fat is this? Is it saturated or unsaturated?
Saturated.
Yeah, it is.
Good fat.
Because it's solid at room temperature. Is it the healthiest fat?
No.
Nope. Of course, anything moderation is the key. I mean, you're better off eating unsaturated fats, consuming them. Cook with olive oil and things like that, it's much better than animal fat. And what you're seeing now is the sac that the heart's sitting in right there. It's kind of cut open at the bottom here because to take it off the diaphragm, they had to cut it. The apex is down here, this heart, and the base with the vessels and auricles and all that would be up here. Let me cut this. I got enough fat off there. I can now cut away this parietal pericardium. And you'll see what I'm talking about the layers. The parietal pericardium consists of two layers. It has an outer fibrous part made of irregular fibrous connective. Adhering to the inside of it is simple squamous membrane. It's technically the tissue is called mesothelium. As any liner of a body cavity is epithelial is mesothelium. But you'll see the two differences in the layers here as I cut it away. Now, where the difficulty for you will be is not so much cutting it away from the heart like this, but removing it from the major vessels. If you're looking at a piece of pericardium and it looks pretty uniform, that's okay. But if you see something dark in it or something more solid, that's very likely a blood vessel, like that right there. See that blood vessel right there? That should be the superior vena cava right there, that vessel right there. And cutting around that is difficult for a person who doesn't know where they're going with it. And if you cut some of those vessels, so be it. I mean, you're not trying to be an expert. You're just trying to learn a little bit from it, cutting away at stuff. I'm cutting a vessel that I know about already. That's a major artery right there that comes off the aorta. But we don't need it right now, so I'm just going to clip it off. And we'll not need to keep that. I'll come along with the scalpel, I'll come along the vena cava and try to isolate it from the pericardium. The thing about it is that this fibrous layer of the pericardium merges right into the outer lining of the vessel, become all one. Vessels are covered by connective tissue with the same stuff here. Okay. So that's why I have to cut it away from this vein here, this vena cava. I always want to watch where my hand is. I'm going to cut across the vena cava this way. And then down it that way. I'll also have some pulmonary veins. The pulmonary veins on this heart are not very easy to locate, believe me. This vessel right here, you see that dark streak there?
Mm-hmm.
See it? Right there. That should be the inferior vena cava. So I'll cut across it, isolating it. I'll keep cutting along all the fat here. And it's probably a pulmonary vein right there. And there's the parietal pericardium. The outer layer with the fat is a little duller. You can see it. And it's very tough. I can press almost with all my might and I can't get through it. Of course, it's been preserved too. That helps strengthen it. See there? Very tough.
Try using your teeth.
So that outer part there is irregular, dense connective tissue, interwoven collagen fibers and so on, elastic fibers. Inside, though, doesn't it look a little shinier?
Yeah.
That's the mesothelial membrane. I'm rubbing my finger over simple squamous membrane right there, the surface of it. It lines that inside. Because you need a smooth lining for the heart to beat against inside, and it's also lubricated too. As it beats in there, it beats against a smooth surface.
So can fat ever go inside of that somehow? Oh, well,
There it is.
Oh, obviously.
There's fat inside.
But
there.
like,
Oh, yeah.
but like, how does it not connect to the smoothness of it and like disrupt something?
Well, you wouldn't have fat on this inner lining here,
It's just a membrane.
because that's just a mesothelial membrane. You would get some as you go around over the heart, because there's a membrane that comes over the heart here too that comes from this same membrane. This exact same membrane will circle back over the heart and become what is called the visceral pericardium. Does anybody know the other name for that? The single name for it, which I prefer really. Means on the heart. Epicardium. Epicardium means on the heart. And if I could get under here with a scalpel, you can see I pick up some of the visceral part there. Make a little hole in it. And get up underneath it.
So it's called the epicardium or the what?
Visceral pericardium, same thing. See that? See that membrane? That's a mesothelial membrane too, that's on the surface of the heart. Underneath that will be the muscle of the heart, which is called myocardium. And we'll see that inside there's another membrane too that lines the inside of the heart and the valves and everything. So this can be called visceral pericardium, or one word, epicardium. Okay. What part of the heart is this?
Apex. Base.
Base up here. We can locate the first, as we should, the chambers. That's an auricle. And this, well, by the way, step back a minute. Let's locate the front of the heart first, or in the case of the sheep, the bottom. We're assuming human, upright stance. This is the anterior surface, posterior back here. Okay. So there's a groove that runs across the front of the heart. You perhaps know by now that it's the anterior interventricular sulcus. It doesn't look much like a sulcus here because it's filled with fat and blood vessels. Pretty flat, really.
Sulcus or septum?
Sulcus.
Sulcus is on the outer surface. Septum is inside. We'll see that.
Interventricular sulcus?
Interventricular sulcus, because it's a groove between the ventricles in the front. That is the auricle. I'm sorry we don't have ability to show everybody, but turn it around on the table or anything. But this is the auricle of the right atrium. This is the auricle of the left atrium over here, the ear-like part of it. Is that one of the assistants in? Okay. This vessel here doesn't look like much until you get your instrument or finger into it. But this is a good-sized vessel right there called the pulmonary trunk artery right there. You don't see it dividing because it's been cut off too short. You may get a heart which shows a pulmonary artery, but this is cut too short. Where the artery would have divided is further out. This big one here, look at the thickness of it, pretty thick. That is the aorta right there. Coming up, it will come like this. This vessel, extremely thin, superior vena cava. If you look at the top of the heart from front to back, you'll find pulmonary trunk going this way. Behind it is the aorta. The aorta will have a little branch sticking up, which I cut off just to get it out of the way. And then behind that, on the toward the posterior aspect of the heart's base will be the superior vena cava. And those are the major vessels. Now there are pulmonary veins, usually cut off a little too short for this. And they would be in this area here. Because if I take my finger, I go right into the left atrium. So that has to be where there were pulmonary veins right there. In fact, I can even go down and feel the bicuspid valve with my pinky right now. Inside. Slam my door and my finger in the door. But anyway, but the vessels you want to locate again are the pulmonary trunk, aorta, superior vena cava, and over here is the inferior vena cava, and I'll show you where I got that in a minute. This will be the right ventricle, and to the left of the sulcus will be the left ventricle. When you're doing, please remember this: when you are doing, you'll follow my lead here too. When you are doing your dissection today, you do not cross that septum there, inside the sulcus, right? And therefore not the sulcus either. The dissections we see in the videos have the heart just cut this way, have two halves. I don't particularly like that. I like to do my dissections that follow the route of blood flow through the heart. It helps you learn it too. So we're going to start internally, going through the right atrium first, through the superior vena cava, and then go down eventually through the tricuspid valve to the right ventricle here. Then back out of the right ventricle through the pulmonary trunk here. Pretend their lungs will be here someplace. We'll come back eventually into the left side over here and cut through the left atrium too. Come down. So we'll follow the blood flow as much as we can anyway. How I do that, which makes things a lot simpler, is I use this metal probe and then cut along the probe. That'll make your dissections much more straightforward. What I do now is I want to go through the vena cava. Let me cut that off again so you can see just how very thin it is. I'll cut some of the fat off around here. Always fat in the way. These little guys are well fed for sure. So I'll cut the vena cava right here again. Every time I put goggles on, I itch. I think it must be the plastic or something. Or it's psychological. You don't want to touch these anymore, right? Put them right there. But anyway, there is the vena cava. Look at the thinness of it. Why is the aorta so thick and the vena cava so thin? Structures have only as much tissue as they need most generally. That's not always the case.
Does the aorta have to pump more or pump harder?
That's a good way to put it. It's not pumping. The aorta does expand and contract as the heart pumps, which aids in the flow of blood. But it's got to be thicker to withstand more pressure is the key. The vena cava has very little blood pressure in it, so it doesn't have to be thick. This one has to be, because if it were as thin as the vena cava, it would have ruptured pretty quickly in this animal. But as it is, it's pretty strong, the aorta is, compared to the vena cava. That's because of the difference in pressure. The pressure is highest leaving your heart, just outside it, and lowest as the blood comes back through the veins by a remarkable amount of pressure. It's a tremendous decrease. So what I'm doing now with this metal probe is I'm going to first probe over through the inferior vena cava to show you that that's right there. See it? That's the superior vena cava up here. There's the inferior down there, and the atrium in between. So you locate both of those, the superior and inferior, and I'm going to pull the probe back out, make a little turn, And the end of this, and by the way, always use the dull end. Don't use this because it'll go right through stuff. You want something that's not going to be puncturing chamber walls and damaging vessels more than we have to get to them. So instead of going this way this time through the vena cava, I'm going to go this way, kind of work my way down through the rest of the atrium. And I feel, right now, I feel the tricuspid valve. I go through it because the valve is facing this way. No problem going through it that way. The cusp of that tricuspid, though they're not very big or anything, they're facing this way. Probe is now like your toe in your shoe. It's right there. It's in the right ventricle. In fact, there's this septum right there. I'm just hitting. I can go about that far. Now what do I want to do? I want to turn this point away from me so I don't end up catching my gloves. Usually you want to put the dull, if you do have it, you have a sharp point to the scissor and a dull point. Put the dull point down and just cut right through the vena cava. Cut through the atrium. I can feel the probe, so I'll know I'm going in the right direction. Just keep it cutting. You have to use a little scalpel, that's fine too. And I can open it up. You see what I mean by following the flow of blood? I've gone from vena cava through right atrium, through tricuspid valve to right ventricle. What kind of circulation is that? Systemic or pulmonary?
Pulmonary.
Pulmonary so far. Yeah. I can kind of open everything there and look in, but I'm still feeling resistance. After all, this heart's been preserved and it's real tough. In fact, it'd probably bounce off the floor if I dropped it. You know, so I want to go the way the blood is going to go to leave the heart. Remember, I said in class that blood is pumped from the bottom of the ventricle upward, pushes it up this way. So I'm going to kind of follow with my probe along the upward path the blood would take, just leaving this ventricle. I feel resistance because the septum between the two ventricles is curved. It's not flat. It's kind of like the left ventricle is circular and the right one's kind of like a little appendage off to the side of it. So we got a curved septum, and I'm going to have to go along that curve. To do that, I can use a scalpel for this as long as I don't hit the probe too much. I'm going to make another incision here. It gives me a little bit more freedom to move here. I need to go a little bit further up. Making sure I'm heading toward this pulmonary trunk, by the way. Heading up that direction. See, I didn't make a full cut there. You're going to be amazed at the difference in the right and left ventricles here, by the way. Now what I've done is I've gone into the pulmonary trunk. Now what valve is the probe pushed through there?
Superior vena cava? Or the
Valve.
Semilunar.
Oh,
yeah.
Which semilunar?
Pulmonary.
Pulmonary.
Pulmonary, precisely. It's right in there. And let's go on up with it. And I'll use a scissors this time so I don't tear it up too badly. You have to cut through the valve, of course. Can't keep it intact. But we'll see a cusp or two of it as you go up through this thing. So there I've gone up to the direction the blood has left the heart. So now I have a little bit more freedom to look at things too. Locate once again, there's the superior. Let me try to hold this so I can. There's the superior vena cava right there, cut open now. The inferior one would be down in the wall here. Discover that later again. This is the right atrium right there. Oh, I'm so sorry. This is flipping all over. Let me get it against the wall over here. There's the right atrium right there. Okay. There's the vena cava. Everybody see that? Okay. There's a cusp of the tricuspid valve right there. See it? I can pick it up. It's stretched pretty tight now because I've opened stuff up. There's another cusp over here. Right there, see it?
Mm-hmm.
And there's one that I cut through. I couldn't help cutting through one of the cusp. There are three of them. What are these strings called?
Chordae.
Chordae tendineae. And they attach to papillary muscle, which isn't all that obvious in this right side. maybe a little bit better one over there. There's a papillary muscle there. There's a papillary muscle there. There are the chordae on each side which are going to them. So they hold the valve as it shuts to make sure it doesn't go back the other way like it should. Oh, here's a pretty good papillary. Can you look? Let me put it that way with the camera. There's a papillary, see it?
Mm-hmm.
And there are the chordae coming on from it, going to the valve edge. Every time this ventricle beats, the papillary muscle contracts, the chordae are pulled, and the cusp is shut properly, as they should. Without the chordae, the cusp would do what? Just flap back and forth. They wouldn't stop the blood flow back to the atrium. You want the blood to go this way and out, not back where it came from. That's the key. And as it goes upward through the right ventricle, it's eventually going to come to the, this is the hardest part of all because it's so small here. But I think maybe you can see one of the cups or cusp of the pulmonary valve. See it? There should be three. There's one there, there's one there, and one I cut through. Now, which way are they facing? The direction of blood flow, right? Blood goes by them once it gets the pressure to open them, but then when it tries to come back during the resting phase of the heart, it's blocked. The valve closes, as it should. The aorta has a similar valve at its base, too, to keep the backflow from occurring. So that's the right side. Notice the thickness of the right ventricle. Maybe as thick as your pinky or so, or maybe less. Maybe, what is that, about 1/4 to 3/8 of an inch, maybe, something like that. Thick. Not very thick at all. What is this wall right here that I'm pointing to, pushing against?
It's the left ventricle.
Well, the left one would be over the other side of
The
that.
septum.
Interventricular septum right there. Yep. Keeps the oxygenated blood on the left side from mixing with the deoxygenated blood over here. The blood over here is deoxygenated still until it goes out to the lungs and comes back to this left side. Now this is, again, the interventricular sulcus. It's inside is the septum. This would be what chamber? Left ventricle, left atrium. Now the internal dissection over here is a lot simpler, but you're going through a thicker wall, so you're going to have to work at it a little bit. The rule is, as I stated when I started this, don't cross this line here. Don't cross this sulcus, and therefore you won't cross the septum. The blood doesn't go that way. It doesn't go through the septum. It goes atrium to ventricle, out through the aortic valve to your body, right? So you don't want to go across there, so I'm going to go about an inch or so to the left of the interventricular sulcus. I'm going to cut right down through the top of the auricle of the left atrium and just go right on to toward the apex. And you watch what I do here. Just go right on down like that. Okay, I made a cut. I'm still not through it. I'm through the atrium, all right. That's pretty thin. I can get my finger in there, but I'm not through that ventricle yet. So I'm going to have to cut a little bit more. Just always watch where the scalpel is. Cut a little more. Pry it apart. Cut a little more. You can cut without getting your finger if you're real careful. What I'm trying to do now is open up the entire left side of the heart here. Now there's part of the bicuspid valve. I can't leave that intact. I must cut it. Unfortunately, I must cut it. That's one of the cusp there with the chordae attached to it. But look when I open the left side up. What difference do you see? Now, let me point out the chambers. There's the left atrium. There's the left ventricle. Look at the wall, how thick it is.
Looks good.
And the sheep is extremely thicker, much thicker than the right side. Look at the right. And us too. Maybe not severely, but in us it's thicker on the left than on the right.
Is that systemic instead of pulmonary?
Yeah. And you know that you could probably figure the reason, right, that it's thicker over here.
Because it pumps
To the
blood
whole
to the whole
Works
body
harder.
system.
It has to be strong enough to pump it everywhere, not just to the lungs. It must develop enough blood pressure to push it out into the aorta, and every part of this sheep's body, and yours has to pump it to every part of your body too. So yours is thicker as well. What valve is this right here? Let me get my pointer. There's one cusp, there's the other.
Aortic
I've flayed it and opened it up, so you can't tell which cusp is which, but the one here would be the anterior cusp, and this one back here is the posterior one. There are just two of them. Look at the thickness of those chordae compared to the other side. Here, listen to that. How strong they are. Look at the size of the papillary muscle. It's strong. It has to be strong over here because of the amount of pressure it produces. If I cut on down through the auricle, I can free myself up a little bit more. If I were to look down this way to the right of the bicuspid valve, I can look in there and see the cusp of the aortic valve. Notice when I probe through this area, and I'm over to the right side of this bicuspid valve. If I probe through there, I'm going to come out there. So that's the route the blood would take as it's pumped from the left ventricle upward, aortic valve, aorta to the sheep's body, right there. Now you may, in your dissection, cut on through and open up the aortic valve. It's really not necessary. You can see it up under there. No big deal. But certainly recognize other structures. Now in the heart, you may have noticed some features, and I forget 34, 35 or something like that in your lab manual. The pectinate muscles and the trabeculae carni. The pectinates are up in the atrium, and they're these comb-like muscles. See these muscles up in there that are irregular? Interestingly, in one of the dissection videos, a guy says it's the smooth part, which it is not. Smooth part of the atrium is not pectinate. The pectinates are these rough-looking ones right there. See them? More in the auricle. Let me point specifically with this to what I'm talking about. I'm holding them right there. See them? I need 4 hands. Pectinates are right in here. They're up in the roof of the atrium. Why you should know about them as a medical, future medical individual is the, of course I'm not sure all of you are going to go into an area that would, you have to know this, but you're going to know it anyway. The significance of pectinate muscles is, of course, that whenever the atrium fills, they kind of stretch out, but then they help contract the atria. But that rough area in there can be a danger to an individual, too. There is a arrhythmia of the heart that you may have been hearing about. They've been advertising it more on TV lately, and the medication is supposed to take care of the blood clotting and everything. AFib, or atrial fibrillation. Fibrillation of the heart chambers when it's contracting totally out of rhythm. It's a quivering bowl of jelly. It's not pumping blood. And it's just doing this sort of thing. You know, it's the electrical signals through it are erratic, and it's not getting the rhythm that it should get to beat like this. It's just going like that, you know. And what can happen in an individual that's in AFib is that clots can form along those pectinates. And those clots can dislodge and go out of the heart and go into the brain, cause a stroke, go into the heart, cause a heart attack, that sort of thing. So there's a danger in AFib, and that's why they want to keep people on the proper medication and so on when they're on that, particularly blood thinners, heart regulators, and so on. Other muscles in the ventricles down here that are quite irregular, like you're seeing down in here, these are, you know, it's not smooth. See how rough the ventricular wall is? Those strips of muscle down there are the trabeculae carni. They're in the ventricles. And they of course, are involved in the pumping of the heart, the electrical signals that go to the ventricles with the Purkinjes and all that, but They're kind of rough. What would the, someone tell me what the membrane is that I'm teasing up right here? Similar to the epicardium, there's one inside, endocardium. It lines the chambers, the valves, the vessels. It's continuous into the vessels, too. The vessels have a thin squamous lining as well. You can think of the heart wall as kind of like a sandwich. It's got the epicardium on the outside, the endocardium inside, and the meat of the sandwich is called the myocardium. That's the workhorse of the heart right there. That's what it's filled with cardiocytes that are cardiac muscle cells that are contracting, or were anyway. Not anymore. So that's my heart. How's your heart? Well, you've got to dissect one and see how well you can do. See if you can do the job I did. You can use this as reference, but you all must, pairs of you must dissect a heart, please.